A very big hello to all my dear students. So, how are you all? So, today we are going to discuss an image based discussions on different 50 images of ophthalmology which you should be knowing very well, right? And how are we going to start and go with this 1 hour of session? We are going to talk questions around it and what is the image, the diagnosis, the findings, and what are the important questions that are asked in the exams. Okay, so all set for NEET PG? Good, good, good. Okay, so let's start with this one by one. First is this image. What is this image all about? So, if I want to describe this image, I am going to describe it as this is your fundus findings. This fundus image, I can see the optic disc. Therefore, this is a central fundus. Okay? I start like this from the basics, and if this is the central fundus, what is happening to the disc? I see a pale waxy disc here. So, this is a pale waxy disc. What else I can see? Pale waxy disc, and I can see the pigment disturbances in form of bony spicules. All of you, can you please tell me what is the diagnosis? Yes, somebody has already said yes. Good afternoon, all of you. So, what is the diagnosis? Yes, Dr. Light, you are here. Okay. So, this is your retinitis pigmentosa, right? And we can also see the attenuation of arteries, right? So, this is the attenuation of arteries, attenuation of arteries. Okay. So, this is the diagnosis is retinitis pigmentosa, right? Okay, what are the things they have asked you about retinitis pigmentosa? What you have to keep in mind? Number one, let's discuss a few important questions. First of all, it is most commonly sporadic, most commonly sporadic. And of course, if it is hereditary, what do we know? The inheritance can be, if hereditary, we will learn this, that inheritance can be either autosomal dominant, autosomal recessive, or X-linked recessive, right? Now, there has been quite a debatable thing which is more common. I think AD should be answered as more common, though yes, it is still debatable. The next important thing is of course the triad which you are seeing in this fundus picture is another exam question. What is the triad of retinitis pigmentosa? So, we all know this. Pale waxy disc is which type of optic atrophy? We have learned it is a consecutive optic atrophy, right? So, it is a consecutive optic atrophy. And what else triad में क्या आता है? Attenuation of arteries and bony spicules. ठीक है? Okay. So, this is which type of atrophy? We will learn it as at consecutive optic atrophy. Okay. What is the next important thing they have asked you is most common systemic association. What will you answer? Most common systemic association, it is Usher's syndrome, right? What is Usher's? It is retinitis pigmentosa with deafness. Usher's syndrome is RP with deafness. What is the next thing? Next thing they will ask you is your, can you think of any other question? Role of docosahexaenoic acid was asked once. Docosahexaenoic acid is a component of rods. As you know, retinitis pigmentosa is mainly what? The retinitis pigmentosa is dystrophy of rods and cones, but mainly it is the dystrophy of rods, isn't it? Rods and cones, but it is mainly the rods which are involved. Now, docosahexaenoic acid is a very, very important component of this rods. So, supplements of this is given and it is seen, though not 100% proved, that it can slow down the progress, okay, that it can slow down the progress, right. Anything else they have asked you in your exams? Which is inverse retinitis pigmentosa. What is inverse means? Do you all know what typical retinitis pigmentosa will start from the mid periphery, okay. So, if it starts from the mid periphery, it is going to involve this area first. So, therefore, the initial, what is the initial field effect? This was also asked, it is ring scotoma, right? And you have learned ring scotoma in glaucoma also, double aqueous scotoma is ring scotoma, but both if options are given, we will mark RP. Be very, very clear with this, right? And then when it extends further, this is where only narrow field is left behind, and this is what is called tunnel vision or tubular vision. So, this is your tunnel vision. ठीक है? Got it all of you? So, what is inverse I was talking about? when instead of mid periphery it starts from the center. So in a typical RP, the vision is going to slowly be affected only in the late stage, because as you can see, the last is the tunnel vision. But when you talk about atypical RPs, inverse RP kya hai? When it is the center which this is also called, the inverse is also called pericentric RP. Okay, inverse RP को और क्या बोलते हैं? We also call pericentric RP. So pericentric क्यों बुलाते हैं? Why? What is pericentric RP? Which means that it starts from center. It starts from the center. Is it okay? So these are some important questions which are asked around retinitis pigmentosa. So we all know it's a genetic disease, and can you also tell me other atypical forms? It can be sectoral, when one sector is involved. Yaad rakhna. Then this one we have learned. Then yes, we have talked about retinitis pigmentosa sign pigmento. What is sign pigmento? It means that instead of these bony spicules, if you get this type of pigment dispersion dot 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 dot, which is salt and pepper fundus, right? So if it is a salt and pepper fundus presentation, we call it RP sign pigmento. ठीक है, इसको क्या बोलते हैं? RP sign pigmento. We all know this, na? So this is another. And of course, if there are white dots, what do you call? RP albicans. White dots is RP albicans. Okay, so these are the atypical types of retinitis pigmentosa. And yes, one more question before I move to my next image. I can remember is, of course, what is the mainstay of treatment, investigation is ERG, है ना? तो ERG में क्या मिलेगा? Decreased amplitude or almost flat waves. That is what you get in ERG. Do you all remember the waves of ERG? Let me just rub this to explain you what are the waves of the ERG we have learnt. So this is your A wave, this is the B wave, and a very small C wave. A stands for rods and cones, and B is for bipolar cells. B for B yaad rakho, bipolar cells. A is for rods and cones, right? So when there is a dystrophy, there is decreased amplitude of A hoga to B hoga. So please remember, in RP it's a flat, decreased amplitude of both A and B waves. Hope you will remember this. This too is your exam question. So these are the questions around RP. It's a very, very important topic for both your MBBS, PG entrance and all. Okay, once we know this, we come to the next image. Okay, can you all now tell me? Very nice, you all are answering nicely. Can you tell me what is this image? I would like to know what is the diagnosis. Khushi, keyhole vision is mainly the term which is used in occipital lobe lesion. When posterior cerebral artery is blocked, the macula sparing homonymous hemianopia that you are getting, that is called keyhole vision. Okay, Khushi? So this is generally called tunnel vision, or the other name of this is tubular vision. So just let's be very, very familiar with the terms. Wow, now this is such a lovely thing. I'm so happy, Kausalya, that the last minute revisions that were done also in my channel and whatever recaps we have done, this is all being so helpful to you all. Thank you so much. So that's the reason I keep saying that keep attending and keep learning along with me, right? Rapid fire discussions at the last moment are always very helpful. So that's, I'm very happy to read this message. Thank you so much. That's very encouraging. I'll continue to support this way, right? Awesome, KP Chaudhary, awesome, God bless. But all of you who have cleared your FMG also, you have to understand that this was only ek padao tha ye, okay? Now you have a bigger milestone in front of you, and very quickly after celebrating, your celebration time should be very smart enough. You shouldn't be keep taking rest for a long time. You have to reboot ourselves very, very quickly, right? So then that's a smart step. And all those who could not clear, please, I got a message, I keep getting both the messages, so I got messages, ma'am, mera nahi hua, and the only thing मैंने जवाब दिया है, होगा, okay? होगा, ज़रूर होगा, get up and get up yourself. Okay, you all are awesome, you all have the same potential, you all will do it. So please try to understand yourself first, right? I will, what do I say all the time for you all? I will never disrespect myself by ever giving up. So please get up yourself, start working harder, harder and harder. There is no reason ki nahi hoga. Okay? So everyone has their own journey, you have your own. Let's focus on ourselves, let's be sincere, and let's try to work harder than yesterday. That should be the motto for all of you. Okay, let's come back to, we have 50 images to discuss here. So what is this? Okay, I would have expected a better answer, not retinoblastoma. Yes, we have to say this picture is a flexed nerve intestina. What you see is the rosates, of course, and these are the true rosates along with the lumen here, right? So this is what we called as flexed nerve intestina. Okay, so flexed nerve intestina is a differentiated form of tumor cells, of course, and we are talking about retinoblastoma. Okay, so very quickly, and just let's revise in and around this retinoblastoma. So first of all, very important is what are the other pathological findings. If you don't get a central lumen, we call it pseudo-rosates. Let's revise it like this, and if this is the case, these pseudo-rosates, they are also called Homerite. Sabko yaad hai na? This is called Homerite pattern. And what is the third? Third is your fluorates. So this is the main pathology, and these are the names of the differentiated form of tumor cells. Chalo, ye to one thing is this. What is the next thing? Next thing that you have to know is about most common mode of presentation. Can you all answer me? It will be more enjoyable. My question is, which is the most common mode of presentation in retinoblastoma? That is one question. As I told you today, I am going to just discuss around questions and image. So, most common mode of presentation, what will you answer? All of you, I will wait for this. Second, my question is most common mode of spread. My third question is most common non-ocular malignancy. Okay, waiting for the answers. And next question is, I'm just putting the questions, I'll answer afterwards because I'm waiting for your answers. And the next question is about second most common mode. Second most common mode of presentation. Okay. Okay. Let me see what you all have answered. Yes, leukocoria. Okay. Most common mode of presentation, leukocoria. So we all know this is white eye reflex, that is leukocoria. Okay. What is the most common mode of spread? This has been again a little point of confusion. You should answer through the optic nerve. Okay, through the optic nerve. And most common non-ocular malignancy, most common non-ocular malignancy is, I am writing here, osteosarcoma. Right? So osteosarcoma. Second most common mode of presentation. Yes, very nice. Many of you are answering so well. Yes, directly by the optic nerve. Yes, Khushi. Second most common mode of presentation, I haven't received this answer. Second most common mode of is strabismus. We will not forget squint or strabismus. Okay? Okay, it can also be a cause of intraocular calcification. We have to remember this. If you look at the B scan, you can see intraocular calcifications. We will remember this as well regarding retinoblastoma. I want you all to kindly please revise your international classification of retinoblastoma, how we divide stage 1 as 5 groups, A, B, C, D, E. Okay, just revise. Time crunch, I cannot take each and every detail, but you should know this, right? Okay, so that was about retinoblastoma. Anything else that yes, and you should also know that it can present as glaucoma, it can present as pseudo-uveitis, it can also present as orbital cellulitis. Why you have to learn? There was a question. Retinoblastoma can present with all these features except. So you have to know it, right? So this is important. Yes, so I think we can, yes, I was missing this question. I was thinking something else is there. What about the gene, RB gene? Where is it located? You will answer 13q14. Okay? So RB gene 30, ये भी पूछा जाता है 13q14, which means if I make my way of simple diagram, 13 chromosomal number, Q is a long arm, P is a short arm. It is the 14th band which is affected. Okay? So we'll say this is your 14th band which is affected. 13q14, right? And if the mutation is even outside the 14th band, now you call it 13q syndrome. What is 13q syndrome? 13q syndrome कब कहते हैं? When along with this retinoblastoma you get dysmorphic features. क्या हैं dysmorphic features? Like frontal prominence, broad nasal bridge. This is called 13q syndrome. चलो last question. Tell me the answer of this question. What is trilateral retinoblastoma? Okay, trilateral retinoblastoma. Okay, Dr. Deviki, so we are doing that. Let's cherish it. Let's focus. So, trilateral retinoblastoma क्या होता है? Bilateral retinoblastoma with penialoma. Bilateral with penialoma. I'll try to take more live sessions, Dr. Deviki. Thank you. So, bilateral retinoblastoma with penialoma. This is ये क्या हो गया? इसी को बोलते हैं हम लोग. This is what we call as trilateral. Okay, trilateral retinoblastoma. Okay, so that was about this image. We come to the next one. Batao, what is this? All of you. Very good. Nicely answered. What is this image, all of you? The diagnosis is absolutely very important. This has been your exam question. Image was asked in the exam. Let us focus here. What do you see apart from these lashes? Yes, very good. This is what is extra row of lash, and this extra row of lash is what is called dystichiasis, right? So, dystichiasis, what are the points to remember? It's a congenital thing. This congenital problem where there is an extra row of eyelash which is posterior to this grey line. That means this will be rubbing on the cornea, and because it can rub on the cornea leading to ulcer and opacification, very very urgently it should be removed. ठीक है, तो इसको remove कैसे करते हैं? You can go for diathermy, cryo, laser, whatever you wanted. Cryo करो या diathermy से you can just remove these lashes, right? So that is about dystichiasis. This is what you have to know, and I hope you know what is trichiasis. Trichiasis क्या था? Very good. Everybody has answered correctly. Awesome. So generally epilation खाली नहीं करते हैं because epilation Pihu, epilation becomes a very temporary thing. Na? Again, it will go very quickly. You want to damage the hair follicle so that it doesn't regrow. So, epilation for a quick method we generally learn in trichiasis and all, but actually it's again a temporary thing. It will regrow, right? Okay, and you all know what is trichiasis? Batao, before I move further, trichiasis kya tha? It was misdirection of eyelash. Misdirection of eyelash. Okay, अगर आपको ये पता है misdirection of eyelash is trichiasis, can you all tell me what is pseudo-trichiasis? Now this is, I will wait for this answer. What is pseudo-trichiasis? What is pseudo-trichiasis? Let me know. What is pseudo-trichiasis? Yeah, trichiasis generally in trachoma or any cause of scarring can lead to misdirection of eyelash. Okay, not only trachoma but other causes of scarring like all types of burns, Stevens-Johnson syndrome and so on. Chalo jaldi batao so that I move to the next image. Pseudo-trichiasis. Very good. Yes, yes. So I got the answers. Yes, Bolinini and Dr. Deviki. Yes, very correct. We will answer when this trichiasis actually primary problem is entropion. So when it is due to entropion. Naturally, khud socho, think with me. The lid margin is turning inside. So even that is causing misdirection of eyelash. So when it is secondary to this entropion, we are going to call it pseudotrichiasis, right? So then we call it pseudotrichiasis. Okay, we come to the next image. All of you, what is the diagnosis? Again on lids only. Why is this lid V-shaped conical lid when the patient is looking down is known as? I don't think I want to answer this, I will wait, right? Very good. So, keratoconus would have been not a very specific answer. Yes, what I expected was Munson sign, and of course it is in keratoconus, not wrong. So, Munson sign is nothing but V-shaped deformity of lower lid on looking down. So, this is happening due to the conical protrusion of eyeball, that is keratoconus. Okay, so few quick revision on keratoconus. Quick questions here. What is the main refractive problem in keratoconus? Conical protrusion. So first, this is one exam question. You will say there is myopia because the curvature is increasing. Along with that, there is irregular astigmatism. Myopia with irregular astigmatism. Very good. Nice, all of you. Okay? So one is this one, myopia with irregular astigmatism. We come to the next thing. Next question that they can ask you is, what is scissors reflex? What is scissors reflex, all of you? Scissors reflex is when I am doing retinoscopy. I hope you all know what is retinoscopy, objective method of refraction. We see the light reflects at the pupillary border. So when you are doing the retinoscopy, you see, generally you see the two light reflexes more like a blade of two scissors and it's moving like this. That is what is called scissors reflex. Okay. So this is what is scissors reflex. Okay, we come to the next question. Next question is about prominent corneal nerves. So why do you get a prominent corneal nerves? This is, they have asked you, this prominency of corneal nerves is due to thinning of cornea. Let's not forget thinning of cornea. Okay, we come to the next question. What is the next question they ask you is oil droplet reflex. I am writing here. So when you say oil droplet reflex, ये कहाँ दिखता है? Oil droplet reflex is mainly seen in, pay attention, we have to say distant direct ophthalmoscopy, right? Distant direct ophthalmoscopy. When you are doing, you see this oil droplet reflex in patients of keratoconus. Next question. Yes, the next thing they can ask you is about what is Fleischer's ring. We will see the image also. We all know this is iron deposition. Iron deposition at the base of the cone is called Fleischer's ring. It is not case of Fleischer, we all know this. Isn't it? We know this? Yes. Okay. So, these are some questions. Then they can ask you what is the definitive treatment of a progressive agar keratoconus hai, to what is the treatment of choice? You will say C3R. I hope you know what is C3R. That is collagen, corneal collagen cross-linking. These are the 3 C's with riboflavin. So, you are giving riboflavin eye drops. Wait for half an hour. Now, expose the eye to UVA rays. Okay. So, this is your riboflavin with UVA rays we are talking about is what is your C3R treatment. Then there is another question, what is the choice of contact lens? Very good, all of you are answering very well. Okay, Dr. Tavish, yes, most commonly it is inferotemporal, right? Then we talk about choice of contact lens. So, if you, I hope you understand this. If this is the cornea, conical cornea, if I use a soft lens, it takes its surface like this. But if I am using a semi-soft or RGP lens, it is going to replace it by the regular surface. So, your answer will be semi-soft lenses or RGP. RGP क्या है? Rigid gas permeable lenses. We are talking about contact lens. Intax is what? Intax is intracorneal inlay, where you are putting the ring inside the corneal stroma, right? So, that is again used to flatten the cornea, right? So, Intax can be one of the options or modalities, but here I was talking about contact lens. I hope this is clear. Yes, you should know Intax. Sangeeta, there are even more signs. Yes, Rizzuti signs where when you are looking from one side through the slit lamp, you can see the tapering and pointing of the light reflex, but whatever has been asked around, I generally focus on that. So, Rizzutis has never been asked to you all in last 25 years. Okay. So, anyway, then we come to these are the questions. Anything else you can remind me, Sangeeta? Anything else we are missing apart from this, all of you? These are some important questions of keratoconus that has been asked. Yes, one more question has been asked. See, I remember. What about whenever there is a protrusion like this, as one of you said, okay, most common inferotemporal. So, there is going to be, yes, this is what I am going to talk about, Devaki, that break in the Descemet's membrane, and that is what is called, that is parallel to the steeper axis, and this is what is Vaux stria. And I think we have also discussed this, and this has been asked, how is this different from HABs? So, I hope you know HABs stria are more circular or horizontal, and they are mainly, of course, a feature of congenital glaucoma. Okay? Chalo, we come to the next image. Yes, now what do you see? I have deliberately put the images mixed so that we can enjoy that discussion. Chapter wise sochte you can get little monotonous, right? So that's why we are getting some sudden interesting images in front of us. Tell me, what is this? Khushi? This is a giant retinal tear. We are not talking about retinoschisis here. It's a giant retinal tear. You are looking at rhegmatogenous retinal detachment, as simple as this. Okay. So when you say rhegmatogenous retinal detachment, इसमें क्या चीज़ें समझनी है? That this is question number 1, most common type of retinal detachment. First of all, most common RD is this. Secondly, this image is telling you that how the patient will complain of as if the curtain is falling in front of the eye from periphery to the center. So this is curtain falling in front of eye. I included this image so that it's clear to you what it means. Okay. So once you know this, any other question we want to discuss on rhegmatogenous, all of you? Yes, and that is Schaffer's sign. Okay. So whenever there is a retinal break, there is pigment dispersion. And that pigment disperses in the vitreous, and that is what is called tobacco dust or Schaffer's sign. It's a sure sign that okay, there has been some retinal break. Okay, so Schaffer's sign पूछा जाता है. Schaffer's sign is asked in the exam, also called tobacco dust. Right, so these are 3 very, very important questions on rhegmatogenous retinal detachment. Of course, you will get a break, you get a gray reflex, right, and other features we all know. ठीक है? Okay. Yes, Pihu, that is tobacco dust appearance. Awesome. Okay, we come to the next. What I just want you to have a look at the slide. Looking all 3 of this, tell me what is the diagnosis. So what do you see? Very quickly, all of you. Okay, very good, Dr. Light. So you say it's a bitemporal hemianopia. If I see the field, this is gone, temporal side, this is temporal side gone. Again, if you look at here, this temporal is not there, है ना, nasal है. Again, nasal है, temporal is not there. ठीक है? So it's a bitemporal hemianopia. So, and what is this then? What is this image? This image is showing you the seesaw nystagmus, one eye up, intorted, down, extorsion. So seesaw nystagmus. Okay, so one additional point here for you all. So what are we talking about? This is your chiasmal lesion. Okay, so we'll say this is chiasmal lesion. Now, should I say something more here? Let me. So when you say chiasmal lesion, have we also not learned that chiasmal lesion can be central, anterior and posterior? So which one is this? Tell me, which one is this bitemporal hemianopia? It is what type of lesion? Central, anterior, posterior, which one? So this is mainly central chiasmal lesion, isn't it? It's a central lesion. That means exactly at the decussation you are getting a lesion out here. Decussation of what? Of nasal fibers, right? So if we very quickly talk about visual pathway, this is your left eye, this is your right eye. Wait. Let me make it a little bigger. Okay, so this is your left eye and this is your right eye, right? And we know that, I'll just go with this very quickly, okay? This is nasal temporal, nasal temporal. We know nasal fibers decussate. This is my way of simplified diagram, just draw this. And temporal will not decussate. And then comes your optic tract, lateral geniculate body, then optic radiations, one from the parietal and temporal lobe, parietal and temporal lobe, and here comes your visual cortex. Yahi hai na? So this is your main visual pathway. So we are saying that when the decussation is happening at this level, where both nasal fibers are gone, this is your central chiasmal lesion. Very good. Now sometimes what happens if this is the decussation here, and actually this is mainly not at the center but at the junction of the chiasma and optic nerve. What do you call that? Junctional scotoma of Trachar, right? So this junctional scot is what? Anterior junction syndrome. We call it anterior junction syndrome. So I forgot to include this image because I was not intending to discuss that long, but I have. So go and check your what is the anterior junction syndrome, how the Wilbrand's knee, which is inferonasal fibers, they are actually affected. And therefore, what you get here? What we get here is a central scotoma, and along with the central scotoma on one side, suppose on this side it is on the left side, we will get opposite side, that is on the right side, superotemporal quadrantopia. Very good. Yes, you all are correct. So what we will say? It is mainly junctional scotoma. Right? Of trachea. Very good, Dr. Devki. I am so proud of you. Every time I tell each and every one of you, please draw the diagrams along with me whenever you are attending my lectures. क्यों? जब अपने हाथ से बनाओगे तो ही याद होता है. You are going to definitely benefit from that. Right? So if you feel lazy, please don't. Just make the last moment, you just look at the diagrams, look at the cues and double cues that I have taught you. That's done. Isn't it? Okay. Yes, thank you, Dr. Devki. I think everybody should see a chat and try to follow this, right? We all should. Yes, Dr. Lai. This is present in pituitary adenoma. When there is any lesion in the pituitary adenoma, it can present as junctional scotoma of trachea. Very good. We come to the next image now. We'll come back to this diagram of visual pathway. Coming to the next image. Now tell me what is the diagnosis. Bolo, what is the diagnosis now? I can see a fundus fluorescein angiography. I can see multiple hyperfluorescent dots on the fundus, and these are nothing but microaneurysms. No, it's not proliferative SK. These are microaneurysms. And what are the two questions on microaneurysms? I'll just solve it for you all. So, because these are multiple microaneurysms, and maybe this is just a dot hemorrhage. This is just a dot hemorrhage. So, it's a very early, if there is a little bit of, you can see these black spots. Can you see these black spots here? This one, that means some hemorrhage or exudate is there, or a exudate. These are blocked fluorescence, isn't it? So when there is a blocked fluorescence with some microaneurysms, it becomes a mild NPDR. Please revise your ETDRS classification of diabetic retinopathy. I have taken it so many times. I think it must be on the YouTube session also. It is there. Okay. तो जो आप very mild क्या था? Only microaneurysms. Mild is what? When you are getting all the features of background diabetic retinopathy. That is your microaneurysms, dot and blot hemorrhage and exudates. Hemorrhage, exudate, microaneurysm. This is mild. Okay. So I'll say here that this is your mild NPTR. Okay. Okay. Then we talk about very important two questions, right? Two questions of microaneurysm, which is the earliest feature of diabetic retinopathy. आपने बोला microaneurysm. Second question is, in which layer? We will now answer NFL layer. Please answer NFL layer. Microaneurysms are present in nerve fiber layer. You should be absolutely very, very thorough with the layers of the retina. Okay. Yeah. Chalo. So we are talking about this diabetic retinal. We come to the next image now. Now tell me, what are you looking at? Look at the two images. Can you tell me what it is? First of all, let's see this one. Let's see this one. What do you see here? I can see a convex configuration of a detached retina. It's already given a written here, that's okay. Hai. This is convex configuration, and which type of RD is this? Exudative retinal detachment. Okay. So this is your exudative retinal detachment. So if it's an exudative retinal detachment, see Priyanka, you always have to tell which detachment. Now up thoda sa ek step further you have to comment. Okay. So yes, exudative, not rhegmatogenous, Dr. Light. This is exudative. Rhegmatogenous, we just saw the giant tear, isn't it? What is this ultrasound B scan telling you? I want to know this because this has been your exam questions, therefore I included. Can anyone tell? Sunil, this is not Stargardt's beta. Tell me this. What is this telling you? So, if this is the ultrasound B scan, let us read it together. Of course, this is the lens and this becomes the vitreous part, and this is the retina which is detached, showing you the retinal detachment, is not it? Very good, Pihu. So, at one position of the head when you do ultrasound, this is the position of your retina. After some time, now this is the position of the detached retina. So, because of lot of shifting fluid. So, shifting fluid हमने पढ़ा है ना, this is your mainly the feature of exudative. So, here you will say due to this shifting fluid, you can see two positions of the retina because it becomes a very mobile retina, right. So, shifting fluid has been asked in your exam. You have to know it's a typical feature of exudative. And what is exudative? I hope, let me remind you, any pathology of the choroid, whether any tumor or anything or any other neovascularization in the choroid, whatever it is, when it percolates into the subretinal space, the RD that it causes is called exudative retinal detachment. Okay, so exudation from the choroid. Okay, that's by the name. Right, we come to the next. Now I want you to have a look at this and tell me what is the diagnosis of this image. The whole slide is one diagnosis. That is why so many slides. The whole slide is one diagnosis. We want to know what it is. Very good, Dr. Lai. This is your pathological myopia. So, if you see, these are lacquer cracks. What were lacquer cracks? Break in the Brooks membrane. I can see annular crescent, this greyish shadow due to peripapillary atrophy. This is your annular crescent, isn't it? Okay, what else do you see apart from annular crescent? Can you see the prominent choroidal blood vessels? This is what is called tigroid fundus. Okay, tigroid fundus or tessellated fundus. Right, what you are seeing here is chorioretinal atrophy. Okay. And what do you see here? I can't see the disc. This is actually a peripheral retina, isn't it? Now, peripheral retina, what are you seeing? What we see here is lattice degeneration, right? And look at this one. This is the ultrasound B scan. And ultrasound B scan, this is showing what? That instead of like this, it is like this. So, what is this? Posterior staphyloma. Okay. So, all these are the features of pathological myopia. All these are features of pathological myopia. Okay, correct? So, just know all these are features of pathological myopia. You all know pathological myopia. How do you define it? Any myopia with fundus changes is pathological. Right. Very nice. Yes, Khushi, Foster-Fuchs spots are also a feature which are nothing but hemorrhage and pigments at the macula. But here it is, we can't see in these slides. But yes, thank you for reminding. We should also know what are Foster-Fuchs spots. These are hemorrhage and pigments at the macula. Hemorrhage and pigments at macula. ठीक है, चलो next पढ़ते हैं. What is this, all of you? So, this is which tonometry? Rebound. We are stabilizing it on the forehead. So, this is nothing but rebound tonometer. Okay, more than 6 DSK is the definition of high myopia. It is not pathological myopia. Pathological myopia is any myopia fundus changes means excessive number going much above like minus 15, 16, 17, 8, 20. So, when there is excessive stretching of the eyeball and due to that stretching of the retina which are causing these changes, we are calling it pathological. So, you cannot demarcate na कि किस number से pathological changes होंगे. It can be varied, but of course common sense says that when the axial length is too long, then only you can get these changes. That's why it's related to very high myopia. More than 6 diopters is the definition of only high myopia, not pathological myopia, right? Okay, very good. This is your rebound tonometer. So, rebound tonometer, but the only important thing you have to know It is used for self-measurement. You can measure your intraocular pressure yourself. Just remember this. So, we get a lot of questions on tonometry. Now, come to this slide. What will you answer? What field effect can you see here? This is your pie in sky. And what is pie in sky? Superior quadrantopia. Did we learn this? Yes. When you go back to your visual pathway lesion, some fibers are going to parietal, some to temporal. So, what did you learn? It is the temporal lobe lesion. It is a feature of temporal lobe lesion, because the Meyer's loop consists of mainly inferior fibers. So, when there is inferior fiber lesion, there has to be a superior field defect, right? Okay. We come to, of course, very quickly also, let us revise that if it is just the opposite, like this. Acha, one more thing before I move further. Wait. Before I come to this one. One more thing. Tell me, एक और चीज बताओ. When you are saying this type of lesion, do you also want, just think with me and you should be clear about this. This is the left eye, right eye. So, you are getting a right-sided superior quadrantopia, right? So, if it is a right-sided superior quadrantopia, which temporal lobe has a problem? It is the left temporal lobe lesion. Okay. So, इसका मतलब left eye में which quadrant is involved? Upper nasal, right में it is upper temporal. Sometimes they can ask you which quadrant is involved, little higher, but this is a smarter question. You should be able to understand and answer this way. Got it? चलो अब आ जाओ, अगर parietal lobe lesion की बात करेंगे, in parietal lobe lesion it is mainly the, when you say parietal lobe lesion, what do you have to know? It is the inferior, it causes inferior quadrantopia. And suppose this time I make a left-sided inferior quadrantopia, then it means it's a right-sided lesion. Okay? So, it's a right-sided lesion. This is left, this is right. What are the quadrants involved? I can see it. It is lower temporal in the left and lower nasal in the right. I think this should be absolutely clear to you all. ठीक है ना? Okay. Okay, Khushi, you have to just understand this way. Whenever we are talking about the field effects, na, left का left, right का right, हमेशा ऐसे ही depict करना है. So, no confusion. If I am talking about field effect, if I am making the visual pathway and writing the field effects, it's left का left, right का right. So, no. ठीक है? समझ आ गया? Okay. When some patient is sitting in front of you, or you are asked the questions on pupillary reactions where you can see, okay, this is his right eye, this is his left eye, then of course you will have to answer according to that. But for pathway lesions, this is how we will know. Is it clear, Khushi? Now you shouldn't be confused anymore. Okay. Okay. We next talk about is this one. Now, can you give me the diagnosis of this condition? The two slides that you see. What is the two images that you're seeing? What is the diagnosis of this slide? Dr. Lai, that will happen only in one eye. So, why will we get the field effect in both eyes here? Yes, you can get a field effect if there is a superior-temporal BRVO, mainly most commonly it is superior-temporal, you may find a field effect, and field is always opposite to anatomy, but it will be only on that one eye. So, that is the main thing you have to understand. Okay? Okay, so flower petal appearance, yes, the diagnosis is cystoid macular edema. Very good. So, CME, first question is this one. It is flower petal appearance on fundus fluorescein angiography. Okay? On you are clear? This is the leakage in a radial manner like this. Why does it happen? I have explained you, because the OP layer is radially placed at the macula. And what is the second? Second, as you can see here, is on OCT, what you see are all these are what? Cystoid spaces. So, this is OCT of your CME. Right. Then I think this is also very important, and they have asked you This time is Irvine gas syndrome. What is Irvine gas? Next question. Irvine gas syndrome is your CME after cataract surgery. CME after cataract surgery. This is what is called Irvine gas syndrome. CME after cataract surgery. And of course, one more thing, when you niacin overdose can also lead to CME. Niacin can lead to CME. These are all important exam questions that you have to keep in mind, right? Yes. Very good. Yes, you all have already told about niacin and this. Very nice. Yeah. Yes, PU. PG analogs will also lead to inflammation cause karta hai, that can lead to cystoid macular edema. Very nice. So let's also add PG analogs. Good. You very nice. We come to the next image now. So these are the important things about CME and these are the questions. Mainly we have to talk about questions. Okay. We next talk about is what is this? All of you? So you are looking at what? Your fundus picture. Can you see the disc? Yes. What is around the disc? Multiple flame shaped hemorrhage. These are the flame shaped hemorrhages. Clear hai? Okay. What else do you see apart from flame shaped hemorrhage? I can also see these cotton wool spots. So yes, very nice. This is your splash sauce appearance, which is a feature of central retinal vein occlusion. Awesome. So we are looking at splash sauce appearance. Very good. Any other question I would like to mention here in CRVO? Yes, one more. 100-day glaucoma. Pushte hai na? So one is splash sauce, another is what is 100-day glaucoma? If you all remember and attended my lecture where I talked about and taught you all about retinitis proliferans, what is this? Hypoxia causes leakage, then more hypoxia, release of chemotactic factors, neovascularization. Padha tha na? And this neovascularization can complicate as vitreous hemorrhage. Then second was tractional retinal detachment and neovascular glaucoma. So in CRVO, especially the ischemic type of CRVO, this is seen as to occur, this neovascular glaucoma occurs exactly after 100 days. Yeah, sometimes we also call it 90-day. So they are not different, it is the same. So this is what is 100-day or 90-day glaucoma, which is called, this is the neovascular glaucoma. Right? Chalo, we come to the next. Now I want you to diagnose, the diagnosis of this slide is what? So let me give you a guess. It is a side effect of which drug? All these are side effects of which drug? Yes, we can go for SK, we can go for the anti-VEGF treatment there. Okay, so you say this is cornea verticillata, very good. This is your vortex keratopathy, also called cornea verticillata. Agreed, right? Also called vortex keratopathy. So this is one. What do you see here? This is the slit lamp and this is the, if you will look here, this is the corneal slit. Okay, cornea ka slit dikh raha hai, cornea. And this is the lens and what I see is posterior subcapsular cataract. Very good. And what do you see here? This is your, yes, this is your bullseye maculopathy. So what is the diagnosis? Which drug are we talking about? Chloroquine. Okay? So we are talking about chloroquine. So chloroquine can lead to these side effects. These are side effects of chloroquine. Posterior subcapsular cataract, corneal verticillata and bullseye maculopathy. Can you tell me cornea verticillata is a side effect of one another drug? I think the causes are many, na? Kya kya hai causes? Chloroquine is one. Please revise with me. Amiodarone, tamoxifen, indomethacin, Fabry's disease, and lastly, let's not forget netarsodil, which is an anti-glaucoma drug, which can also lead to cornea verticillata. That is netarsodil. Very nice. Yes. Okay, we come to the next. Look at this image. What is the diagnosis of this image? What I see here is cherry red spot. So if you are looking at a cherry red spot with edema all around, and the second image is very strongly telling me, okay, in this case, there is some dual blood supply to the macula. What is this artery known as? Cilio-retinal artery. isn't it? So, what are we talking about? Central retinal artery occlusion. Very good. So, central retinal artery occlusion, first question is this one. Second question, if the patient still retains central vision, he has coeloretinal artery. Third question, this is a branch of which artery? You will say it's a branch of short posterior ciliary artery, right? Ciliary system. ठीक है यहाँ तक? And only central vision, a little bit of the field will be left. So, this actually is a cause of tunnel vision. What else? Of course, what is the time limit when you should very quickly treat CRAO if possible is only 90 minutes. Treatment 90 minutes. If we can't treat within 90 minutes, there will be irreversible damage to the retina, right? Of course, the main cause is embolism. What is the next cause is another question. Next question, what is the next cause? You should answer mucormycosis can be another cause of CRAO, right? So, these are the causes. And yes, thank you Sangeeta again for reminding me about one more important question, and that is Holland-Hotz plaques. What are Holland-Hotz plaques? These are again your cholesterol emboli. Hotz plaques are nothing but cholesterol emboli. Good. Very good. Yes, it can lead to, Sangeeta, it can lead to relative afferent pupillary defect. Okay, what is the diagnosis of this image? Again, left and right, you can see एक का nasal गया, one का temporal, both on one side. So, this is your right homonymous hemianopia. So, this is your right homonymous hemianopia. Okay? So, when you say right homonymous hemianopia, the lesion would be on the left side. Now, homonymous hemianopia can be caused by tract lesion, irradiation in the posterior part, or in cortical lesion. But we all know that when we talk about a cortical lesion, we know this. If I talk about visual cortex lesion, then you have to talk about macula sparing homonymous hemianopia, where macula is spared because it is mainly due to blockage of posterior cerebral artery. So, this type of homonymous hemianopia is macula sparing, and as one of you had asked me, this macula sparing homonymous hemianopia is what is called keyhole vision. Okay, not visual field defect. Keyhole visual field defect is a feature of LGB lesion. Keyhole vision is seen is nothing but macula sparing homonymous hemianopia. Got it? So, what should you answer? Generally, most commonly, if this type of thing is asked, our first answer has to be optic tract lesion. So, in this case, as you can see, it's a right homonymous hemianopia. So, we will say it's a left optic tract lesion, right? So, don't forget this, and also revise your vernix semiamyopic pupil, which is seen in optic tract lesion. Kindly revise that. MBBS Insights, deep respect for you for writing this. We really need a lot of courage and pure heart to do this. Okay? You will know everything, each and every point. Let's work hard from today, this moment on. Okay? There is no replacement of hard work and there is no shortcut. This has to be absolutely very clear to all of you. Okay, we come to the next image, and what is this image? Sorry, I have to go quickly. We have some time limits here. So, when you talk about this image, what is this? All of you, we can see hyphae here. Yes, we are talking about keratomycosis. So, keratomycosis, what are the questions to be asked in the exam? Let's see. First question is that this is signs are more than symptoms compared to bacterial. Why will you get a keratomycosis? A repeated question. I am making a double Q. Because of trauma by vegetative matter. Okay. So, trauma by a vegetative matter or organic matter. Dandi se chot lag gayi, patti se chot lag gayi. So, trauma by any twig or leaf. What is the third question they have asked you is most common fungus involving the cornea is Aspergillus fumigatus, isn't it? And which is the next common, if this is not asked, will be fusarium. Okay, then you will say fusarium. MBBS Insights, hope you are noting down each and everything, whether you know or not know. Just note down. Always sit with a copy when you are attending the lectures. So, this is your fusarium and Aspergillus fumigatus. Second option will be fusarium. Yes, very good. Many of you have reminded me. The next question they can ask you is satellite nodules. What are satellite nodules? We know this, that any lesion apart from the main lesion. And if I go back to my diagram, everything is learnt very quickly, that if this is your fungal ulcer, it has a dry, rough look. We have talked about dry, rough look. Then hyphae. Then we have talked about another question. Yes, it is unsterile hypopion, right? This is another, so many questions. Can you see that? So it's an unsterile hypopion. Another question, what is the drug of choice of keratomycosis? We will answer natamycin, 5% natamycin, right? So these are some very quick questions. Anything I'm missing? Yes. Anil, can you DM me? We can talk about it later. Let's focus on images, and if you're still having a lot of headache, you can just take a break and see the session later. Don't torture yourself. Listen, to be very honest to you, let me tell you something. I have taken many classes in headaches. And this is a fact, many classes. And I would say, okay, whatever it is, I have to teach. And generally by the end of the session, uh, it is gone because of all my awesome students sitting and I'm busy talking to them. So let's keep fighting. Okay, we come to the next. ये बताओ, what is this? Next image, ये बताओ. You have to say this is a Maddox rod test and this is a Maddox rod with spherocylindrical lenses here, isn't it? So if this is the right eye of the patient and left eye of the patient, are you all alert? Should I speak? So the right eye, say the patient is seeing a vertical line, from his left eye he is seeing a spot of light. So the patient is looking at a spot of light. Now you have put the Maddox rod. From the eye in which you put the Maddox rod, in this case it is his right eye, it becomes a line and the next other eye is only a spot. So what did you conclude? Two dissimilar images which cannot fuse. So artificially you have created diplopia. So if you have created diplopia artificial, now you ask the patient about the orientation of these line and the spot, isn't it? If everything is normal, if there is no phoria, what are we detecting? This is done for phorias. You are trying to detect latent squint. This is your phorias or latent squint, isn't it? तो अगर आप बोलता है मरीज, if he says okay the line is passing through the spot, this is no horizontal phoria, everything is fine. But if he says no, now the line is to my left and the spot is to my right. So if it is left, do you understand it's a cross, because line is on the right side on his right eye, but he is seeing the line on the left. So this is a cross diplopia. Cross diplopia hai, which is seen in which type of squint? We have learnt it like this. If you remember my diagram, make a cross, make an arrow. Cross diplopia is mainly seen in exotrophorias or tropias. So that is why it is written exophoria. And if he says no, right side mein right line dikh rahi, left side is spot, it is uncrossed. And in uncrossed, what you go for? We go for, then uncrossed is, again make the diagram, you'll never forget. No crossing means it's a ESO. In convergent, there is no crossing. So it's a ESO4. And how do you correct it? This is written, na? So naturally, if it's an exo, base will be, base is always opposite to the direction of squint in a prism correction. Please remember. So if there is an exo, the base in rakhenge. If there is ESO, base out rakhenge. Okay? Yes. Very good. So this is about, no, this is for, not for palsy, Dr. Light. We are not talking about palsy, means it's a tropia. This test is mainly done for phorias, which are latent squints. Okay? Yes, palsy you can, I think you were mentioning in relation to your crossed and uncrossed diplopia, if I am not wrong. Yes. In tropias also crossed and uncrossed. So if it is uncrossed diplopia, it's a convergent squint. That means there is a lateral rectus palsy. In a crossed diplopia, it's a divergent squint. It's a medial rectus palsy. So this is for tropias, for the manifest squint. Chalo, next batao. Yes, very good. Wesley's ring, all of you, I missed this Wesley's ring. So Wesley's ring is an immune ring. Yes, actually it can be seen in fungal, viral and few bacterial infections also, but yes, your first answer has to be fungal. So you can say. Very good, Tavish. This is your anterior lenticonus. The diagnosis is correct. So anterior lenticonus is this one, and what do you see here? Because of anterior lenticonus, when you see this patient in a retroillumination, what do I see? This is your oil globule reflex, isn't it? This is oil globule reflex. Okay? Questions, all of you. First question, anterior lenticonus is a feature of Alport syndrome. Another question, another syndrome you should know, Waardenburg syndrome. Chalega? Ab third question is, it is more common in males. Okay? We'll remember all this. It is more common in males. And please remember, there was one question, I think in your NICT or so, where they had asked you that Alport syndrome, all other features except. So you should know this. In Alports, both anterior and posterior lenticonus is a feature, but because anterior lenticonus is most prominent, most common, we learn it A for A, Alports anterior lenticonus. Okay? Please remember. Okay. So that was about this image. Come to this one. Now tell me, what is the diagnosis? So what is the diagnosis here now, all of you? This is your, I can see this is the corneal slit. This one is the corneal section. Now the light is passing, this is the lens section. And what I see these additional opacities like this also. You know? So this is called riders. Very good. So we are talking about lamellar cataract, which is a type of congenital cataract. Okay. So lamellar cataract, what are the questions? First question for the lamellar cataract, all of you, is that this is the most common congenital cataract causing marked diminution of vision. Okay. Second question was on riders. We have taken this already. Riders are a feature of lamellar. Third question is, which vitamin deficiency causes lamellar? You will say vitamin D deficiency causes lamellar cataract. But most common congenital cataract, Sangeeta, is blue dot. Most common congenital causing diminution of vision, it is lamellar. So there is a difference. Okay? Yes. Okay, it is mainly including the fetal nucleus. Remember this. Overall करके नहीं पूछेगा. Overall अगर बोलता है, if they are not mentioning congenital, it is an acquired cataract we are talking about, right? Whenever it says acquired cataract, we will say radial spokes. Okay? Which is your, what is that? Radial spokes becomes the most common cortical form of cataract, to be very honest. So overall, it is not like mentioned anywhere very specifically. Okay, we come to the next image. Batao, what is this? No, mainly Devki, lamellar we can see lamellar cataracts in rubella infection, not galactosemia. Rubella infections में भी आपको lamellar मिल सकता है. Yes, very good. This is your dendritic ulcer. Okay. And why we are saying it's a true dendritic ulcer? I think everybody knows. This is asked in the exam. It has knobbed ends. So because of the knobbed ends, we know these are dendritic ulcer with the knobbed ends. Okay. So dendritic ulcer is a feature of, please don't say only overall herpes, it is only herpes simplex keratitis. It is not a feature of zoster. Please remember this. Second question, steroids are contraindicated in a dendritic ulcer. So many times, it's a double Q. So many times I have asked you this. So why steroids are contraindicated? Because otherwise it can lead to geographical ulcer, corneal perforation and so on. Right? So please, we will remember this dendritic ulcer. And what are pseudodendrites? Where you don't get a knobbed ends. You can see that in zoster infection. Okay, I want the diagnosis of this slide, please. HS1 ही होगा देवकी mainly. 2 comes in the picture when there is through the genital na infections, like in case of ophthalmia neonatorum you have learned that it is HSV2. ठीक, तो okay, we come to this one. What is the diagnosis? बताओ. Very good, Dr. Light. Inverted umbrella. तो सीधा umbrella लग रहा है. It's not inverted. This is mushroom shape. This is called smokestack appearance, right? Let's call it smokestack appearance. This is your enlarging ink blot appearance. Okay. I can also see this ring reflex ka thoda sa, this ring, because nothing but shallow retinal detachment. This is your ring reflex. And what we see here is your distortion of image, which is called metamorphopsia. Yes, we are talking about CSR as a whole, right? So these are important questions. Question number 1, 2, 3. Next question. Next question is that in acute form, this is the acute CSR, acute disease. It is self-limiting. We will not forget that. It doesn't need any treatment. अपने आप ठीक हो जाएगा. It is self-limiting. इसके बाद what is the next question is, where is the fluid accumulated? So fluid accumulation is happening in the subretinal space. Subretinal space. And yes, even this is asked in the exam, that it is mainly a disease of young males. So male is to female ratio is 3:1. It is not, it will not happen in females at all. But yes, young males is what you have to remember. Ah, Devki, that is correct. I was not able to recall that. Yes. If it is a G-put deficiency, it causes oil droplet cataract, and if it is a galactokinase deficiency, it causes lamellar cataract. That's correct. Sorry, I was not able to recall that. This is my thing only. I teach like this only. Abhi मैं slip कर गया. So many things going in my mind. Yes, Devki, thank you. Yes, very good. Type A personality में common होता है CSR, and another one important point is steroids are contraindicated. This was also an exam question. Steroids are contraindicated in CSR. हाँ, oil droplet जो है, that is due to Sangeeta, that is due to what did I say? The oil droplet cataract will be due to the G-put deficiency, that is galactose phosphoruridyl transferase. Now it's clear? So to be very honest, I am really enjoying this discussion because of your active involvement and answering. So thank you so much. We come to the next one. Now what is this is, we all know what is this. We have just included this to revise with you all. You all should know and revise the action of muscles. Coming to the yoke muscles which are shown here, very quickly revising with you. When you look to the right, it is the right lateral, left medial. When you look at the left, it is your left lateral, right medial. ये तो clear है? Now what are the muscles for dextro elevation, dextro depression, levo elevation, levo depression? So we all know, you have learned from me that in an outward deviated eye, action of elevation and depression is only of recti. Inward deviated, it is only of obliques. So अगर हम कहते हैं dextro elevation, which eye is outward? Right. So recti of right will work, oblique of the left, because oblique is looking inwards. Got it? So I hope you know this. We have written in the box also so many times in the class that in an outward deviated eye, if you have not, please note it down. I am repeating again. In an outward deviated eye, the action of elevation and depression is of recti. The action of elevation and depression is of recti. ठीक है, लिख लेना. अब इसको पढ़ो. Whenever I ask you what is the muscle acting in dextro elevation, so what will you say? So instead of, don't mug it up anything, okay? If you know this much, you can answer everything. Learn in the way I am telling you. It will become life is simple here. ये हो गया dextro elevation की बात कर रहे हैं. Elevation में first of all thing divided into two parts this question. First, what are the muscles which elevate? So muscles which elevate are superior rectus and inferior oblique. Okay, which eye, which muscle? It is dextro. So which eye is outward is right. So what will be the muscles acting here? You will say it is right superior rectus, left inferior oblique. ठीक है ना, ऐसे ही पढ़ते हैं ना. And suppose I say levo depression. So now this is what this diagram is also telling you. If it is a right gaze, the right superior rectus, left inferior oblique. Now levo depression, levo is left, outward eye will be the left eye. Which eye is depressed, which muscles will depress? Inferior rectus, superior oblique. Outward eye में recti काम करेगा, so left inferior rectus and right superior oblique. ठीक है? So please remember this way. So this is what you are seeing. This is your levo depression. This becomes your levo depression. हाँ, very good. पूरा opposite. Thank you देवकीत. So आप क्या देखते हो? How very quickly to solve? Right का left हो गया, superior का inferior, recti का oblique. So you can just quickly tell the yoke muscle. So if I ask you what is the, suppose I ask you what is the yoke muscle of left inferior rectus. If you don't have time to again think so, just very quickly go ahead. Right का करो left, inferior का करो superior, recti का करो oblique. So this is the yoke muscle of left inferior rectus. So this is how we answer for vertical muscles. Right? Okay. Okay, what is this slide, all of you? What is the diagnosis? Kanhu Charandas, what is, you did not understand? Okay, I will repeat again. I am repeating again for you. So we are saying ये चीज़ एक fact है जो आपको याद करनी है. You have to remember this, that when you are, suppose, okay, look at this. I am looking at this pen. My right eye is looking outward, my left eye is looking towards the nose. This much you understand? We have to know this fact that in an outward deviated, now if you look at the lectures, if you listen to my lectures, you will, I have explained you why this is so. क्यों ऐसा होता है कि outward deviated eye में सिर्फ recti and काम करती है? Because the axis of the line of action of recti and that of the eye becomes same. Okay, so in an outward deviated eye, what we are saying is it is the recti which will act maximum. Okay, I am repeating for you. I hope you are listening. So when you say dextro elevation, first you should be very thorough about action of muscles. So if you think about the vertical muscles, दो ही होंगे ना, superior rectus, inferior rectus, superior oblique, inferior oblique. यही है ना चार. तो दो recti ये वाली है. Horizontal, we are not talking about horizontal muscles at present. So what are the muscles which elevate? You know it is superior rectus and inferior oblique. When I am talking about right side देख रही हूँ, मैं सीधे ऊपर नहीं देख रही हूँ. I am looking right side and up. So what is my eye which is outward is right eye. So it is the recti of the right will work. समझ आई बात? एलिवेशन कौन कौन सी मसल कर रही है? सुपीरियर रेक्टस, इंफीरियर ऑब्लिक. राइट आई में रेक्टाई काम करेगी, लेफ्ट की ऑब्लिक काम करेगी. वाई? बिकॉज आउटवर्ड डेविएटेड आई में रेक्टाई ही काम करती है. ये नियम है. इज इट नाउ क्लियर? ओके, जस्ट रिमेंबर दैट दिस सिन वर्ड इज नॉट समथिंग आई दैट. सो मैंने उसको इस ऐड कर दिया, आई एस कर दिया है ना. So anyway, we come to this image. This image is what, all of you, it's written also. This is your shield cataract. So why shield? Because the pupillary border is all hidden here. Therefore, we call it shield cataract. Question is, it is seen in which condition? You will answer atopic dermatitis. Atopic dermatitis. Okay, one more thing I will ask you. Another question. Where do you get shield ulcer? Batao, where do we get shield ulcer? Great. Thank you, you understood. Thank you, Kan. I am happy you understood. So, shield ulcer बताओ. Shield ulcer कहाँ मिलता है? आप बोलोगे? Anyone? Can you answer me? Is a feature of shield ulcer is nothing but micro erosions with deposition of mucus. It's a feature of vernal keratoconjunctivitis. Very good. Very nice. Chalo, we come to the next slide. Now, what about this one? So, you know we are talking about astigmatism and we have to know this very simple. If one axis is focusing correctly, one is in front of the retina, this is your simple myopic. This becomes simple hypermetropic. One ray is behind, one axis is focusing behind, one is on the retina. Here both axes are in front of the retina, it's a compound myopic, matlab both eye they will be minus. Here both eye will be plus and here it is mixed, one plus and one minus. So this is one way of classifying astigmatism. Now I would like to revise with you all. The other way was what? The other way of classifying astigmatism was with the rule and against the rule. So, let us see this one. So, this is your with the rule astigmatism, matlab it is the vertical which is more than the horizontal. When this is more, it is with the rule. When horizontal is more than the vertical, now this is your against the rule astigmatism. Pata hai na? This one you know? Okay. So, once we know this, we are clear. Very quickly, one or two things I will ask you. All of you, if it is -2 and -1, tell me according to the two classifications, what type of astigmatism is this? So, I will take 3 examples, that is it, very quickly. So, tell me. If you don't, if you Ritesh, if you are not interested in writing yourself, it will become more difficult for you. Please keep writing yourself, you will get whatever you are asking for, don't worry. But please write it and revise it, ठीक है? अपने diagrams बना लेना. Okay, so both classifications, Pihu, both classifications. Minus means compound myopic, दोनों minus है. And -2 का मतलब क्या है? Where is the power more? I hope you all remember this. I taught you this way. Minus is myopia, M for M, minus is more power. So when you say -2, emetropia ka power is 60, this becomes 60 plus 2. And here this will become 60 plus 1. So vertical is more than horizontal, so it is with the rule astigmatism. Okay, come to example number 2. This was number 1, we come to example number 2. Now tell me, what type of astigmatism is this? Yes, Deviki, that was compound myopic. Now this one, I will give you 3 examples I said. Very quickly. ये कौन सा है? Tell me. Why is there a question mark? I don't understand. That really upsets me. Not really, but yes, why Tavish? क्या चीज question mark क्यों लगाया? 0 means emetropia. Emetropia का मतलब, what is the power here? Power will be 60 diopters. Here it is 61 diopters. Naturally, it is against the rule, and this is simple myopic. Right? Very good. Yes, so many people are not sure. Everybody is putting a question mark also. So it is against the rule, and this is how you have to think. I am deliberately telling you 0 matlab 60 diopters minus 1. Agar plus hota to, if it was like this 0 and plus 1, now this was 60 diopters and this would become 60 minus 1 because plus is hypermetropia. Hypermetropia is less power. So now this would have become with the rule astigmatism had this been a plus. I think this clarifies many things. ठीक है? Because now this would be 60 and this would become 59. ठीक है? So this is how we solve. Now we come to the last example for you all. Tell me what type, all of you be alert. What type of astigmatism is this? Question number 3. What type of astigmatism? Tavish, if you know the crux of it in any question form, in any language it comes, you will be able to answer. Or maybe you are you talking about the prescription form you are saying? Okay, you answer me this one. So this is Pihu, what is this? Pihu, this is not compound hypermetropic, this is not astigmatism. There is no difference in power between the two principal axes. ठीक है बेटे? So be alert. This is not astigmatism. So many of you are writing. So that was the trick. I think Tavish, what you are asking for is, suppose there is a question, I will just put it like this, -3 diopter spherical plus 2 diopter cylinder at 90 degree. What type of astigmatism? So it's very simple, you convert into retinoscopy. When you say -3 spherical, it means spherical हर जगह number दे रहा है. +2 cylinder at 90 मतलब power opposite होता है, because axis is mentioned opposite in a prescription. So 90 का मतलब, well, I am going to put this +2 here. So it becomes -3 and -1. So again this will be with the rule astigmatism or compound myopic. So this is the way we solve. This is what you meant, Tavish? Okay, we come to the next now image. What is this? All of you. These are two different images with some similar names. We have already talked about Fleischer's ring. It's an iron deposition. And where do you see? See, this is your Fleischer's ring. So, this is at the base of the cone. You are looking at which through cobalt filter under slit lamp. I think one of the questions was on cobalt filter as well. You should know this. So, this is your iron deposition. Okay. So, when you say iron deposition, the next question is which layer? You will say epithelium. Yes, the first one, this is your Kayser-Fleischer ring, and Kayser-Fleischer ring is on the Descemet's membrane, right? So, we will remember all this. Okay. One more important question on Kayser-Fleischer ring, that it is mainly Kayser-Fleischer ring. It will be seen in all patients of Wilson's disease with neurological complications, but with hepatic involvement, it may not be all patients. Only 65 to 70% of patients with hepatic involvement will present with KF ring. This was your INI-CT question. So, you should know this. KF ring starts from above and below and then becomes a circle. So, these are the things asked around Kayser-Fleischer ring. Very good. So, Sunil, I think you have understood your mistake. Okay, the percentage is very, very variable, written differently in different sources. You may not learn it. What you have to know, not all patients with hepatic involvement will present with KF ring. Sunil, I hope you realize this, that when it was +4, दोनों 4 है तो astigmatism ही नहीं है. इसलिए please don't continue answering compound hypermetropic. This is not astigmatism. Okay. Okay, can you tell me what is this? What is common? What is the diagnosis of this slide? To be honest, Devki, this gene name you remember, I don't remember. Okay, what is this? Tell me. What you are looking out here is your cobblestone appearance, isn't it? So, we are talking about vernal keratoconjunctivitis. And if you look here, what are these? Denny Morgan folds. This is showing you these ये जो लाइनें बन जाती हैं आँख के नीचे due to too much of rubbing. These are called Denny Morgan folds. Okay, and then what else? What you see here is your keratoconus क्यों बना है? Because too much of rubbing can complicate. So VKC may a complication can be keratoconus. The complication can be keratoconus, right? Okay. So once we have understood this slide, a few more questions on VKC, all of you. Another thing is they have asked you about Maxwell-Lewin sign. Maxwell-Lewin sign is pseudomembrane on this cobblestone, that is called Maxwell-Lewin. Next question they have asked you is about which type of hypersensitivity? It is type 1 hypersensitivity reaction. And in the limbal form, of course, another question is Horner-Trantas spots. Horner-Trantas spots. Right? And of course, I think you all know it is more common in male children and it is mainly seen in summer season. Okay, what about this one? Already taught you this is not dendritic, there are no knob dents here. So, this is what is called pseudodendrites, and pseudodendrites are a feature of herpes zoster ophthalmicus. So, herpes zoster, they ask you what is Hutchinson's rule. I hope you all remember this. Hutchinson's rule is when the tip of the nose is involved, it's a rule eye will be involved. That is what is Hutchinson's rule. Okay, we come to the next. What is this? Everybody knows? This is for screening of the color blindness. We are looking at Ishihara chart. Okay? This is screening for screening purposes and it only can detect red-green blindness. We will not forget this, please. Red-green blindness. Yes. What is this? This time these are not flat raised areas, it is not papillary hypertrophy, these are follicles, these are sago grain like follicles. Yes, we are talking about trachoma, right. So, when you say trachoma, a lot of questions. Chalo, padu one by one. One is this, second they have asked you what is Art's line. You all know it's a linear scarring in a scarring stage of trachoma. है ना? We should also know about Herbert follicles and Herbert pits. You all remember that? Simple diagram is this one. What we see, learn here, the same follicles on the upper palpebral, as you can see this one, and it can be on the upper limbus. These are called Herbert follicles. Whenever there is a scarring, there will be pitting and scarring here, and this is what is called Herbert pits, right? Okay. What else they have asked you? We will not forget repeated questions, safe strategy, okay? Surgery, antibiotic, facial hygiene and environmental cleanliness. Please don't forget that, they ask you so many times. What is the drug of choice of treatment of trachoma? It should be azithromycin. We all know that, azithromycin. And even for the drug of choice for mass therapy for prevention, again it is always safe strategy में क्या use कर रहे हैं? Azithromycin. ठीक है? And then what is the indication of safe? More than 10% of trachoma follicles. This should be the prevalence. If this is the prevalence in an area, we go for safe strategy. It has to be, yes, of course trachoma is eradicated, that is why you are asking this question, I know that, but still if they ask you about safe, this is same. So, mainly the active cases of trachoma is eradicated, which I know, but there are still cases with scarring and complications which have to be dealt with. Okay. Okay, we come to this question. What is this? This image, batao. Dose किसका देव की? Azithromycin 20 milligrams. Azithro का dose तो 20 milligrams per kg in children. Adults में आप लोग एजिथ्राल कभी ना कभी तो खाई होगी 500 milligrams. नहीं सॉरी 1 gram total खाते हैं ना. So it is 1 gram in adults for this one. For trachoma ये याद रखो. And for adults it is 1 gram in adults. ठीक है देव की? Okay, Raksh Chaudhary. For the betterment of the eye, you have to have your minimum exposure to your screen, which whatever is avoidable should be avoided, right? Always remember to blink more so that you don't land up in dry eye. Keep this illumination of your screen to the lesser. Not too much brighter screens should be there. But otherwise, please don't put any eye drops or anything unless and until it is needed. Okay? Yeah. The tears are sufficient. Only when you start having some symptoms, then only we treat. So there's always this type of thought process also. Okay, something to put in eye to keep them healthy. No, not needed unless indicated. Okay, yeah. We come to the next one. What is this? Anybody? Nobody has answered. Batao. This is your pinhole, right? Pinhole. Pinhole, first question they ask you about is what is the size of pinhole? It is 1 mm or 1.2 mm. Right? How much can be neutralized with a pinhole? Up to 3 diopters can be neutralized. And the third question they have asked you is about pinhole test. We all know what is pinhole test. You are giving a specs to the patient. If after putting the pinhole, there is the patient sees the same, that means your refractive correction is fine. But if the vision is improving, then it means there is still some refractive error. So, if vision improves, if there is improvement, then that means the patient still has some refractive error. And if it deteriorates, if the vision goes down, visual acuity नीचे चली गई, then this is either some central opacity like corneal or lenticular opacity, or it could be just a macular lesion, also a macular disease or central opacities or central opacity, right? So, that this was about pinhole. We come to this slide. So, what about this one? क्या है ये? Bitot spot. We all know we are talking about Bitot spot. We have to know about xerophthalmia, important topic. So Bitot spot, first question, it is more common. You will say temporally. ठीक है? Okay, then another question on vitamin A deficiencies. Earliest feature of vitamin A deficiency, you should answer night blindness, that is nyctalopia, right? Okay, then so many times you all have confusion about the treatment. It is 1 lakh international unit, injectable की बात कर रही हूँ. Treatment, if the patient is more than 1 year, we go for injectable 1 lakh international unit on 0, 1 and 14th day. 0, 1 and 14th, okay. So it is 1 lakh international unit of injectable vitamin A on 0, 1 and 14th day. And if the patient is less than 1 year of age, in that case just half the dose. And if you are giving oral, then in each case you have to just double the dose. Double the dose. Double of injectable is oral. Is it now clear? Okay. And do you all remember one more question on secondary and primary signs of xerophthalmia? So primary signs matlab it is only exclusive for xerophthalmia. Secondary means that it can be seen in other conditions. Go back to your WHO grading, just revise your XN, X1, AB, X2, X3. I hope you remember. So what are the secondary signs? Just revise this, okay, if you don't remember. So what are the secondary signs? You will say secondary signs are XN, nyctalopia, XS, corneal scarring, and XF, that is your xerophthalmic fundus. These are called secondary signs of vitamin A deficiency. Okay. Okay, what is the diagnosis of this slide, all of you? I can see here, what is this? What I see here is heterochromia iridis. I can even see cataract in this eye, and this is the lighter or hypochromic. So affected eye is hypochromic with heterochromia iridis. Secondly, what I see? You have to tell me the diagnosis. These are stellate KPs with feathery ends. Okay. Then what I see? I can see this diffuse iris atrophy. Okay. Because of this diffuse iris atrophy, there are exposed blood vessels. Therefore, when I do a paracentesis, I can see bleeding on paracentesis, which is called Amsler's sign. Yes, we are talking about. Ab bata do. What is the diagnosis? Yes, this is Fuchs heterochromic cyclitis. I think we have just covered all the important points here. Fuchs heterochromic cyclitis, right? And remember, it's an atypical anti-uveitis जहाँ पे redness, pain ये सब नहीं मिलेगा. So no role of steroids or cycloplegics. We just manage the complications. Okay. What are the main complications? Of course, main complications are complicated cataract, secondary glaucoma. Okay, we come to the next. What is this? So this is your Goldman tonometry. Goldman tonometer or tonometry. First important, this is the gold standard, right? But we all know that even here the reading will depend on the central corneal thickness. If this is a thick cornea, you overestimate the IOP. In thin cornea, we underestimate the IOP, right? We will remember this. Okay. Then we talk about here is, there is another question which is more reliable, Shiod's or Goldman. I think you know this is Goldman. Okay. Okay. We come to the next one. What is this image? I can see the fundus, no disc, it's little periphery. Along these blood vessels, along this darker one, thicker one is a vein. You can see segmental venous sheathing. Can we see that? Yes, we are talking about candle wax drippings. So, very important question here, candle wax drippings. Okay. So, candle wax drippings kahan padha tha? This is a feature of sarcoidosis. Sarcoidosis. Not salmon patch. Tavish, salmon patch you see in the cornea. Okay, we come to this image. What is this? So, if you see here what we are doing, we have done, which step is this? You are tearing the capsule in a round manner. This is your capsulorhexis, CCC. This is continuous curvilinear capsulorhexis, curvilinear capsulorhexis. Right, okay. This is continuous curvilinear capsulorhexis. Okay, we come to this slide. All of you, the CT scan finding here very quickly, let me revise with you all. Here you can see that the tendons are spare, only the belly of the muscle is involved. So, this is your thyroid eye disease. So, you are looking at thyroid myopathy. Okay. So, this is your thyroid myopathy. So, exam question, which is the first muscle to be involved? You will answer first muscle to be involved is inferior rectus. Okay. What do you see in the next one? In the next one we see is a fusiform enlargement of optic nerve. Fusiform enlargement of optic nerve. So, we are talking about optic nerve glioma. It is optic nerve glioma, isn't it? And here what you see is a tubular enlargement of optic nerve. So, it is a tubular enlargement and I can also see some calcification. So, we are talking about meningioma, optic nerve meningiomas. This is your optic nerve meningioma. Yes, very good. Okay, so you should be able to recognize all these three CTs, it's important. What is this? I think we all know this. Which ring are we talking about? This is your Vossius ring. So, Vossius ring is imprint of iris pigment on the anterior capsule of the lens. So, this iris pigment. So, what are the questions? It's a feature of number one question, blunt trauma, isn't it? Blunt trauma. And what do you see? Where is it located? You will say it is in the anterior capsule of the lens. So, these are the two important questions. Okay, what is this, all of you? Again, while we are talking about blunt trauma, this reminds of us of iridodialysis. So, what is iridodialysis? This is disinsertion of iris from its root. So, it is disinsertion of iris from its root. And what is the next question? It will lead to, everyone, this will lead to what? Which type of pupil? It is a D-shaped pupil. Okay. So, this is going to lead to D-shaped pupil. Very good. Next. Okay, so here we are. We have to remember our horizontal gaze center. Don't forget this. Let us learn it in my way. This is the PPRF or horizontal gaze center of your right side. So, the right PPRF manages the lateral rectus of the right side. It is a supranuclear control. Please don't get confused. It is first going to order the nucleus of sixth nerve, then the sixth nerve, and then it will affect on the muscle. And opposite side. So, if I have to look at the right side, my right PPRF will contract my right lateral, and for the contralateral side, I take the help, I will order the left sided medial longitudinal fasciculus, and it is the left medial MLF which will order the left MR, right. So, left medial orders the left MR. This is also if C lateral. So, what is contralateral is one eye PPRF, other side MLF. And we all know any lesion of MLF is what is internuclear ophthalmoplegia. This is what is shown here. So, this is central when the patient is looking in the right is fine, when on the left no adduction on the affected side. So, this is what you get in INO. If MLF is gone, that side MR innervation will be gone. So, no adduction, but the opposite eye will start showing ataxic nystagmus. Okay. So, please revise all this. This is your internuclear ophthalmoplegia. Okay. So, what did you learn? That when यहाँ पे देखो, if you look at this simple diagram, you will understand जिस side की MLF गई, that side MR innervation is gone, means no adduction on that side. So, if I ask you in this case, which side MLF lesion, it's simple. This is the right eye of the patient, this is the left. Devaki, now you can understand, it's already given, this is right eye and this is left. So, if I think you were the one who had asked me, I am not sure, whoever had asked me about right and left. So, if you look here, it is the right eye which is defective adduction, because right side का MLF गया. So right, which MLF lesion, how will you know? The side where there is no adduction, that side the MLF is gone. This is what I meant to say. So you will answer here right MLF lesion. ठीक है ना? तो ये आपका यहाँ पे adduction नहीं है, ये abductant, तो ये क्या हो गया? Right MLF lesion. So hope this is absolutely very clear. How the horizontal gaze center is PPRF. PPRF order करेगा एक तरफ की LR को lateral rectus nucleus nerve, that is sixth nerve, and then sixth nerve is going to innervate the lateral rectus. So उस side की LR is constrained. Opposite side ordering the MLF. MLF will order the MR. Right? So if PPRF is gone, then that side no horizontal gaze. That's called horizontal gaze palsy. And one last important thing is about FEF, that this PPRF is actually managed by contralateral frontal eye field. So this is the important information. It is managed by contralateral frontal eye field. So if frontal eye field center is gone, it is going to lead to contralateral horizontal gaze palsy. Good. This is not 1.5 syndrome. Dr. Light, Kunal Jain. What is 1.5 syndrome? एक ही तरफ की दोनों चली जाए. PPRF and MLF both are gone. Just imagine in this diagram, suppose I tell you very quickly, right MLF is gone and also right PPRF is gone and also right MLF is gone. Okay. So I am now explaining you 1.5 syndrome. Focus करो. एक ही तरफ की PPRF and MLF चली गई. So if right PPRF is gone, then this side no abduction because LR will not work, and opposite side no innervation to the MLF, so no adduction here. But I am saying the side where PPRF is gone, MLF is also gone, because right side MLF is gone as well here, no adduction on this side. जिस side की MLF जाती है वहाँ adduction नहीं होता. So now one side both are gone and one side only adduction is gone. So this becomes 1.5 syndrome. I hope it is clarified now. Okay, so let's go to the next one. We come to this. So what is this slide? All of you, can you guess what is this slide you're looking at? Very important, asked in the exam. This is your headlight in fog appearance, right? This is what is headlight in fog. Very good, SK. This is your toxoplasmosis. This is happening because of intense vitritis. And because of this vitritis, these choroiditis patches that you see, it looks you're looking in the fog due to this intense vitritis, right? This is your toxoplasmosis. This is one question on toxoplasmosis. Second question on toxoplasmosis is the most common parasitic ocular infection of adults. Okay, so most common infection in adults. Very good. When it is going to heal, it is going to lead to punched out pigmented lesions, and toxoplasmosis most commonly involves the macular area. Now what you are looking at? Batao, what are we looking at now? Yes, this is what is your, if this is the maxillary sinus and the background of the maxillary sinus is all black here, isn't it? And what you see, this is all black here. This is the opacity which is herniating like this. This is what is teardrop sign. Very good. So this is a teardrop sign, has been asked so many times in your exam. It's a double Q. It's a feature of blowout fractures. Chalo, kuch question batao. Blowout fracture is fracture of floor. Correct? Okay. Most common site of floor fracture, posteromedial part. Okay? Just remember posteromedial part. What are you now looking at? So if you see this patient, when you show light, sluggish or no reaction here, but on the right eye there is a reaction. When you show a near stimulus like a finger, so accommodation is present, but when the finger is removed, it is still in the same position, that is cannot revert back, stonic. Yes, we are talking about Holmes-Adie pupil. Okay, so Holmes-Adie pupil. Right. Holmes-Adie pupil mainly seen in middle-aged females. One point, middle-aged females. Okay, and generally, what is the position of Holmes-Adie? They will ask you. affected eye is mid-dilated. This is what she notices. There's difference in the pupil size in her eye. There's a lot of photophobia in the daytime. And mainly the question is, what is the position of pupil? You will say it is mid-dilated, right? And let's not forget the pilocarpine test. If you give very low percentage of pilocarpine here, your Holmes-Adie pupil will constrict. Why? Because of denervation hypersensitivity, right? So, we will remember this. Very good. What is this? Okay, sorry, this is repeated here. I think I didn't realize. This is your Goldman tonometer. Okay, what is this? So, what we have just learned that if there is a thick cornea, we overestimate the IOP in Goldman. In a thin, we don't. In a thin, we underestimate, I mean to say. What is this? This is your Pascal's DCT. This is called dynamic contour tonometer. And what is the advantage over Goldman? That intraocular pressure is not actually depending on central corneal thickness. Great. Yes, Tavish, very good. If they ask you which is the weakest wall of the orbit, then please answer medial wall. Yes. Okay, what is this? What I can see here is a ring lesion, and this is nothing but due to acanthamoeba keratitis. So, this acanthamoeba keratitis, all of you, is mainly first question. It is a rare infection, not common, but it will occur contact lens, washing the lenses with tap water. But if they ask you, all of you, most common infection after contact lens use, then most common infection after contact lens use क्या बोलोगे? आप बोलोगे Pseudomonas. ठीक है ना? They've asked you what is the culture. Next question, culture media, non-nutrient agar with E. coli. Next question, drug of choice, PHMB, polyhexamethylene biguanides. Okay, so non-nutrient agar with E. coli is the culture, which is an drug of choice, polyhexamethylene biguanide. These are the questions around acanthamoeba. Okay, what is this investigation, all of you? What do you see here? This is your direct ophthalmoscopy, where you take very close, the instrument has to be taken close to the eye. This is your direct ophthalmoscopy. Question was, which eye of examiner, which eye of the patient? I think you can see it is right eye to right eye, same eye for examiner and for the patient. And what do you instruct the patient? To look straight, not in the light. If he looks in the light, the pupil is going to constrict. Okay? And I hope you all know this and you have revised that in direct magnification is 15 times, indirect it is 3 times or 5 times. Direct mein you see mainly the images, virtual and erect. Please revise all that. है ना? In indirect it was real and inverted. This is mainly used to see the central retina with a field of 2 disc diameter. What is 1 disc diameter? 1.5 millimeters. Whereas if we talk about indirect, it is mainly less magnification, more field of 8 dd and mainly seen for use for peripheral retina. Okay, so revise both. Can you tell me what is this image showing you? Yes, Dr. Light, it is 15 into 15 in direct. So, we can see more lashes on this side than this side. Can we appreciate that? So, this is what is called hypertrichosis, and this is mainly a side effect of which anti-glaucoma drug? Prostaglandin analogs. Please remember this and please revise your side effects of anti-glaucoma drugs. Okay, what is this slide? I need a diagnosis on this slide. I will wait for you all to speak. Bolo. So, what I see here is cotton wool spots, which are multiple. More, what are cotton wool spots? Soft exudates. What are soft exudates? They are dead axons. So, multiple cotton wool spots mean lot of hypoxia. Please try to understand this way. That means itne sare dead axons and debris, axonal debris is there. Okay. So, this is mainly what you are showing, HIV induced microangiopathy. This slide is HIV induced microangiopathy. Okay, so this is the exam question, all of you. Most common ocular feature of HIV, that is microangiopathy. Then what do you see next? Yes, so this one is typically, Dr. Light, this type of figure is typically not called pizza pie, it is more pizza pie, dekhna, that looks little different. This one is called sauce and cheese retinopathy. So next question, most common opportunist infection of HIV. Opportunist infection, we are talking about CMV retinitis. And this is what you see, this is the picture of sauce is the hemorrhage and cheese is the necrosis. So this is your sauce and cheese retinopathy. Sauce and cheese retinopathy. Got it? And what does this say? This is an important question here, that if a patient is on heart therapy, he starts developing most common side effect is again uveitis, and that is what is called immune recovery uveitis. Most commonly it is vitritis, so we will say most commonly it is intermediate uveitis or vitritis. But actually it can cause all anterior uveitis, intermediate and posterior. Okay, so this is another important question on giving heart therapy. What is the most common side effect? Okay, what are you looking up now? This is your blockage. You see here, this is a slide of dacrocystography, where on one side I can see this is an NLD block, right, which you can see here is the distended sac. This is the lacrimal sac which is distended. And what you see here is a filling defect, mostly due to stone, filling defects. So this is your dacrocystography, right? Okay. So all of you, where do we make the opening in DCR? Few questions here. Make the opening in DCR. You will say middle meatus. If we do a DCR, we make an opening in middle meatus, right? Of course, the NLD opens where? NLD opens in inferior meatus. Which side? You will say it is anteriorly, opens in anteriorly. Okay. What is this? Of course, this is a slide of what type of cataract can you see here? Can you see this? If I outline this, what type of cataract is this? All this. See, this is your PSC. Okay. So, this is your posterior subcapsular cataract. Okay, sorry. What is the other name of posterior subcapsular cataract? Pehla question. It is called cupuliform cataract. Okay, next question all of you. Which cataract will cause maximum diminution of vision? Maximum diminution of vision, it is your PSC. Which lenticular opacity? It is PSC. Next question. Most common complicated cataract, it is PSC. Okay. Next question. Most common radiational cataract, again you should answer PSC. Okay. So, these are the questions around cupuliform cataract. Okay. So, that was all regarding these images. We discussed more than 50 images, to be honest. There were so many in a single slide as well, so that you can assimilate things more nicely and conveniently. So, hope you enjoyed the session. Any questions? If you missed something, you can DM me, of course. But anything that you want to know before we end the session? Okay, so I think it's done, and hope you really enjoyed the session and revised, and whatever points that you could not, you think you have forgotten, hope you have noted down on your copy and you're going to revise it again. And all those who feel they don't know much, it is never late. Let's start from this moment on. Okay, so thank you so much. Stay blessed. Keep smiling. You want to ask a question, Anu Singh? Yes, can you DM or you want to ask here only? MBBS insights, you have to study. If you have to make anything strong, you have to put your time and energy into it. You just need to study along. That you will see that everything is very simple. Just follow the notes, follow the lectures, and just attend all these test and discussion series and image discussion series. Okay. Okay, Anu. Devki, I don't expect this question from you. You all know that first it has to be all the lecture, then only rapid revision is for revision. The name itself is rapid revision. How can you expect to only study that and then say, okay, everything will be done? Then why? Doesn't make much sense. You have to first attend the lectures, make the notes, study, and then when you go with the rapid revision, nobody can stop you from doing well. That is 100% sure. Okay. Thank you, Dr. Light. Thank you, Kanu. Thank you, everyone. Thank you, Sangeeta. Thank you, thank you. Yes, once you have done, you have to go for the full revision. Yes, Devki, then RR is very good. I think so. It should be you. One should be the one to telling me whether it is good or not. So go for the RR. And any doubts, of course, I'm sitting here. Right? You can DM me and we can discuss. So sometimes even this happens that the students think that, acha, main ye message karu, so maybe it's not clear, the answer is not clear. So if there is any explanation needed, I sometimes even send a voice message. So don't worry, you will always be answered. I can be late, sometimes accidentally I miss messages, that's absolutely a very different thing, but I generally keep it, this is, I just make sure that I am there to answer your queries all the time, okay? Yeah. Stay blessed, MBBS Insights. Yeah, thank you, Devki, thank you. Yes, and recently at least 3-4 messages were missed by me, so I was feeling very bad about it. Then I messaged later. So that can happen accidentally. Sometimes we are busy, we miss something, but don't worry, we are always there, and I keep this, that I really am very serious about this, that I come back to you all as soon as possible. So that will never happen. Okay? Yeah. So thank you so much. Thank you. So thank you.